Here's a USMLE-style question on beta-1 receptors in nephrology. Question: a 60-year-old man with a history of hypertension and heart failure is admitted with worsening edema and shortness of breath. He is currently on metoprolol, a beta-1 selective blocker, and furosemide. His vital signs show a blood pressure of 130/75 millimeters Hg and a heart rate of 58 bpm. Laboratory results show serum sodium 139 milliex per bleed, serum potassium 4.1 milliex per bleed, serum creatinine 1.3 milligrams, urine sodium 18 milligrams per bleed. Which of the following mechanisms is primarily responsible for the decrease in renin release in this patient on metoprolol? A. Beta-1 receptor blockade decreases the release of renin from juxtaglomerular cells. Increased sodium delivery to the macula densa stimulates renin release. C. Activation of beta-1 receptors on juxtaglomerular cells stimulates renin release. Alpha-1 receptor activation in the kidneys increases renin release. E. Beta-2 receptor activation in the afferent arteriole increases renin release. Answer A. Beta-1 receptor blockade decreases the release of renin from juxtaglomerular cells. Explanation: metoprolol is a beta-1 selective blocker, which inhibits the beta-1 adrenergic receptors primarily found on juxtaglomerular JG cells of the kidneys. These receptors are involved in stimulating the release of renin in response to factors like low blood pressure, low sodium delivery to the macula densa, and sympathetic nervous system activation. Beta-1 receptor blockade by metoprolol decreases renin release from juxtaglomerular cells. This reduces the activation of the renin-angiotensin-aldosterone system RAS, which is crucial in regulating blood pressure and fluid balance. The reduction in renin leads to decreased aldosterone secretion, contributing to lower blood pressure and fluid retention. Key points about beta-1 receptors in nephrology: beta-1 adrenergic receptors on juxtaglomerular cells stimulate renin release when activated by sympathetic stimulation or low renal perfusion. Beta-1 blockers, e.g. metoprolol, reduce renin release by antagonizing these receptors, leading to decreased RAS activity. RAS regulation. Angiotensin II raises blood pressure by causing vasoconstriction and stimulating aldosterone release, which promotes sodium and water retention in the kidneys. Why other choices are incorrect? B. Increased sodium delivery to the macula densa stimulates renin release. Incorrect. Increased sodium delivery to the macula densa actually inhibits renin release. When sodium is abundant, the body perceives no need to increase blood volume or pressure. C. Activation of beta-1 receptors on juxtaglomerular cells stimulates renin release. Correct pathway for normal function of beta-1 receptors, but this is not what occurs with beta-1 blockade, which inhibits renin release. D. Alpha-1 receptor activation in the kidneys increases renin release. Alpha-1 receptors are involved in vascular smooth muscle contraction and vasoconstriction, not in the regulation of renin release. E. Beta-2 receptor activation in the afferent arteriole increases renin release. Beta-2 receptors are not involved in renin release regulation in the kidneys. They affect smooth muscle relaxation, e.g. bronchodilation. Clinical relevance. Beta-1 selective blockers, e.g. metoprolol, atenolol, are commonly used in hypertension and heart failure because they decrease heart rate and renin release, which lowers blood pressure and helps prevent further kidney damage and heart failure. Beta-1 blockers can be particularly useful in patients with heart failure who have reduced ejection fraction, HFrEF, as they reduce sympathetic overdrive, which can otherwise be detrimental.